speak today at this very prestigious conclave, and we will talk about how integration of diagnostics is actually helping not only in diagnosing disease, but as a part of preventive diagnostics. So I take you through integrated diagnostics, the way ahead. Now, what is integrated diagnostics? It is combining of pathology, lab medicine, radiology, nuclear medicine, genomics. As we can see, these different diagnostic modalities have mutual interdependence, but have very limited touch points. We need deeply integrated workflows, we need to communicate with each other, and we need to move beyond the traditional radiological pathological correlation if we are actually to help the patient realize the full potential of the technologies available today. Now, this is a term we put on PubMed. This has really gained popularity in the last few years. If we look at what it was from 1989, and then suddenly there is a spurt in this term in 2021, and this really means that this concept is at least finding mind space amongst doctors. Currently, how does diagnostics work? We have the treating doctor at the pinnacle, at the top, and below that we have lab medicine, pathology, radiology and nuclear medicine and genomics and few other branches. And these individually interact with the treating doctor. So really the treating doctor is fed so much of data, there are so many new tests and scans available that at times it may be very difficult for the treating doctor to assimilate all the information. What is the future ideal state? For that, between the treating doctor and these departments of lab medicine, pathology, radiology and genomics, there is a layer in between which I, for the want of a better word, call an integrated diagnostician. So this diagnostician will get information, data, scans from all these various departments and be the intermediary, making sense of all this data and then giving it to the treating doctor who can do what he does best, that is treat. So he doesn't have to spend time and expend his brain on trying to put everything together. That is something that is given to him in a kind of digested form by this integrated diagnostician. What are the challenges this integrated diagnostician faces or will face? Challenges that we face today also. He has too much of data in terms of volume, variety across patients, diversity across modalities and departments, and there is really, if you ask me, too much data for human processing. While at the same time there is too little data. How can that be? That is because available data is unstructured. It is fragmented. There is free text data with person-to-person variation. There is data even within the same hospital system which is broken. There is also a great reluctance among healthcare workers to share data within hospital systems, across hospital systems, across geographies, and most importantly, for a lot of things that we do, there is lack of normative data, and that is very important if we are looking at disease prevention. Now, if we look at COVID-19 as a case for learning, the world is going through the greatest crisis in recent past. Thankfully, it seems to have come down dramatically in the last few months. Despite honest attempts at sharing data and experiences from each other across the last 2.5 years or so, the tools and regulations for sharing, analyzing, decision-making across the world were far from ideal. This is when everyone wanted to share data. Could we have controlled or limited the impact of this pandemic? if more robust methodologies, engines of rapid data sharing and disease response were in place. Also, we saw that across the world, hundreds of groups created AI algorithms for chest X-rays, HRCT, but did they really make a difference? What can we learn from this apparent failure when the intent was right? The learning is that we must collaborate across hospital systems, across departments, across geographies, across states in the world. Solution may lie in using artificial intelligence, but there are too many algorithms and no easy way for clinicians to access all. Algorithms are too narrow. Most algorithms ignore clinical and lab parameters. Currently, they analyze images, not patients. There is no easy way to test artificial intelligence. There is limited real-world evidence, and clinical workflow integration still remains a challenge, despite the advancement that computer science has made in the last decade. AI solutions need to overcome technical and integrative shortcomings to be clinically valid and acceptable. Now, where are we today? We have already integrated tumor boards where everyone meets. You have the oncologist, the oncosurgeon, the radiotherapist, the radiologist, nuclear medicine physician, the pathologist, all sitting in one room. Is that really necessary? We can actually have, as is shown here, an integrated diagnostic workstation. And the classical example is breast cancer, where images, radiologists, pathologists are viewed all side by side and can be reviewed remotely. They've got used to online integration in the past 2.5 years of the pandemic, and this can instantly resolve any differences, provide a reconciled report in all concordant cases, improve quality, reduce risk, and as I said, a breast cancer, like you see, this is a mammography, that's the ultrasound here, and that's pathology, histology slides, all of them put together on one workstation, and this is really integration of diagnostics. We set up an advanced clinical next-gen sequencing lab in an imaging facility. This is our attempt at integration or at integrated diagnostics. So in our center at Subject Development Area of Zidayati in Delhi, we do everything from hemoglobin all the way up to genome sequencing, and from X-ray all the way up through ultrasound, CT, MRI, all the way up to digital PET CT. And the idea is to bring them all together under one roof, and to the best of our knowledge, this is the first clinical imaging and genomics setup anywhere in this part of the world, and probably we believe that this is the future. So there can be a single patient-centric window for the clinician where the radiology, pathology, the surgical procedure, what needs to be done, can all be brought together into one window where all of us can look at it and give our own opinions, and hence the patient will get the best out of each and every department that's there. This also enables radiogenomics analytics in the future with genomics data, detailed imaging data, be it CT, MRI, ultrasound, PET, and clinical follow-up data, all together for analysis using computers, hopefully in the future artificial intelligence algorithms helping this, and the integrated diagnostician would also have some kind of AI with him, helping him to be able to put all the data, huge amount of data that he gets. So machine learning systems will be helping in analysis of all of this in the future. Does the future of screening and preventive health, coming back to the topic proper, lie in integrated diagnostics? And this is an example. Patients usually ask a question, do I have cancer right now? They want to know. And that can be shown, the current status, by whole body MRI or any other imaging technique that you may choose, that can answer the question, do I have cancer right now? And then the other question that is asked is, what is my risk of getting cancer in the future? And the same may apply to heart disease or to stroke or to dementia or to liver disease. And this is genetic risk by exome sequencing, by next-gen sequencers. We can tell the genetic risk. The acquired risk can be obtained by detailed history takings, history of tobacco, smoking, exposure to carcinogens, viral infections, exposure to radiations, and so on and so forth. And the current status to answer this question of, do I have cancer right now? And based on all of this, determining which is the best screening protocol for an individual patient. This is actually the harbinger of precision health, of predictive medicine, of preventive medicine, and AI will be the bedrock on which this will be made possible. Hospital of the future will have an integrated diagnostics department, and like I said, all different departments will be in sync with this integrated diagnostic department. So, integrated diagnostician would be AI enabled in the middle between the various departments below and the treating physician. There is the Integrated Diagnostic Institute, clinical diagnostics, imaging, pathology, genomics. We will have innovation, we will have diagnostic optimization, population health and integrated screening, all helped by data. Remember, we are in the age of evidence-based medicine, and it is data leading to evidence which will show us the right path towards personalized health checks. And we've already started providing personalized health checks in our centers. And then, of course, there'll be disease-based oncology, neurodegenerative, cardiometabolic, pediatric, etc., so on and so forth. And, of course, research being a very this is what we had envisaged as our center, where we would where we have 3 MRI scanners and a CT scanner in the basement, waiting area, and parking on the ground floor. All ultrasounds, X-rays, CBCT, DEXA, all of these on the first floor, molecular imaging, gamma camera, PET-CT on the second floor. Third floor would be genomics, path lab, artificial intelligence, and the fourth floor would be for teaching, academics, conference halls, so on and so forth. And this is what the center looks like. And so I would conclude by quoting Jack Welch, the legendary chairman of GE Healthcare, or GE globally, and he said, change before you have to, and also that we should control our own destiny or someone else will. Time has come for the medical profession, and especially the diagnostics industry, to come together in this new evolving era of integrated diagnostics. Thank you all so very much for your attention, and thank you for giving me this opportunity to address you. Thank you very much.